We're very excited you guys can join us today and have an awesome presentation in store for you. So for those of you who are not familiar with the Pediatric Success Series, this is an educational series which is sponsored by Office Practicum. It provides best practice strategies for avoiding burnout, surviving in today's ever-changing healthcare environment, and improving clinical and financial outcomes of pediatric practices. Today's webinar is one of the many live events in this series. If you would like to have the industry news, thought leadership articles, and educational webinar invites sent directly to your inbox, feel free to sign up for the Pediatric Success Series at pediatricsuccessseries.com. Throughout the year, we'll send you the latest pediatric-specific content directly to your email. While you're on your site, be sure to check and other resources that we have available. Up on the screen, you can see a snapshot of the microsite that has just been launched for the Pediatric Success Series, and you can easily sign up for this series by clicking the sign up page, which is circled in green right on the screen for you, and then you'll be entered right in to the series and you are able to unsubscribe at any time. Now to get into the meat of it, our presenter today is Dr. Susan Kressly. Dr. Kressly has been in pediatric private practice since 1989, and she continues to run her own NCQA Level 3 medical home, the recipient of the 2017 HIMSS Ambulatory Davies Award. She is board certified in pediatrics and clinical informatics, as well as a fellow of the American Academy of Pediatrics, where she has several leadership roles related to health IT and practice management. She also serves as a medical director at Office Practicum, where she is responsible for new product development. And with that, it gives me great pleasure to introduce you all to Dr. Kressly.
Thanks so much, Kimmy, for that introduction, and thank you all for joining us today. Our learning objectives you see in front of you, and we're really going to talk about what we're all in the middle of currently, which is trying to maximize the amount of our patients and families that receive influenza vaccination. We're going to talk a little bit about why this matters so much and how to be creative in balancing the needs of your practice and your families, and how to accomplish this difficult work on a regular basis. So where is the impact to your flu immunization rates? And I would start with always my North Star, which is it's essential to great patient care. If we lead with what's good for the patient, our business model should follow and support that. And we also have to remember that there are many patients in our communities, including our infants younger than 6 months of age, and some of our immunocompromised patients and family members and community members, that having our children in our practice immunized also protects the community as well as the patient. There is no reason that your flu vaccination and immunization programs in your practice should not be profitable. Without the SOPA mantra of no margin, no mission, we deserve to be well paid appropriately for the services we provide, and that allows us to have the resources to care for our entire patient population. But it's also important to remember that flu immunization rates impacts our quality metrics, and a lot of us are get paid for performance bonuses around vaccine rates, including immunizations. So when we look at the financial impact to your practice, you have to look at a couple of pieces of this granularly. And clearly there's a difference between the cost that we have to purchase the product itself, and some of that can be lowered by being part of a vaccine purchasing group, and everyone should be part of some kind of vaccine purchasing group, or you are reducing your ability to have profit on your vaccines. There is different margin on different products, and so we'll talk a little bit later about the difference in what you're getting paid and what it costs you to get different products, and you always want to do that math every year. Often the payers lag behind a year, so there may be new products it's a significant number of vaccines. In the world of microfinance, when you multiply a small number by a large number, it still has big impact. Remember that vaccine administration fees, and I realize that this is limited, but still there for VFC patients. There are differences in a lot of our contracts for private pay between counseling and non-counseling codes, and it may determine where you put your best efforts to get children immunized. There are pay for performance metrics, the Every Child by 2 metric that most of us know as childhood immunizations, and that is a HEDIS metric we're going to look at a little bit, includes influenza vaccine. And remember, if you are a high performer, you can use your vaccine and quality metrics to leverage contract negotiations in the future to be able to get paid better for everything that you do. So the HEDIS measure childhood immunization status is not only DTaP, IPV, MMR, and those you see in front of you, but now also includes 2 influenza vaccines by the child's 2nd birthday. And that means that once they are 2 years and 1 day old, if they get their flu vaccine later than that, it does not count. So some payers have this also separated out. Some of them will give you partial credit for the non-flu and separate for flu or a rolled up measure, but they're all important. And remember that HEDIS measures were created for the health plans, the payers, to demonstrate that they are giving good quality care to their insureds. But the payers cannot provide care. They require us to provide the care. So their HEDIS measures, which they have to report to NCQA, fall back to us and downstream to us, so that they often incent us to do better so that they look better when they have to report their numbers. So remember that this childhood immunization status now includes 2 flu by their 2nd birthday. There are other related quality metrics that some of our listeners may be subject to based on their payer mix. There is a National Quality Forum measure that is about if you were seen between October 1 and March 31 and had a preventative care service, did you get a flu vaccine at the same time or have report of having a flu vaccine? And some payers have other specific measures, including asthma patients with a diagnosis of asthma also receiving a flu vaccine. So I would encourage all of the listeners to contact their payers and find out what your quality metrics that you're being subject to are that include flu. And if you do not believe that, you should ask your payers. The American Academy of Pediatrics now reports that over 50% of our member pediatricians have some sort of value-based payment in addition to their baseline payment, and most of that is based on quality, and immunizations are core to that measure. So you may be leaving money on the table in pay for performance. If you haven't inquired or you have a new practice, please contact your major payers and find out if they are available to you. And if you're a rock star in giving immunizations, that's a great leverage point for you to negotiate better contracts. So this is a yearly challenge, and it always seems like we're still giving flu vaccine and treating kids with influenza when the pharmaceutical companies come knocking on our door and say, hey, we need you to pre-book in February for your following season, which is a little crazy, but it is the world that we live in, and so it is the hoops that we have to learn to jump through appropriately. We know that every year the product choices get even more complex. And with that, the ACIP guidance often is not officially released till August. We have to order a vaccine in February, which we sometimes receive in July, and the official guidance doesn't come up till August, which always makes this crazy crunch time in August and September. We know that our delivery dates are unpredictable. Clearly this year was an example of that. And we also know that delivery dates are different for products and for the funding source. Often VFC and private vaccine do not arrive in your office at the same time, which provides a unique challenge, which we're going to discuss. We also know that community pharmacies, urgent cares, and others often receive our supply in advance of us. And so it's always really exciting to drive by the urgent care or the pharmacy to say, come get your flu vaccine in the beginning of August, when we're still trying to figure out when we're getting our vaccines and how would you communicate this effectively to our patients and families. So how do we get most of our patients immunized in our medical home, which should be the goal of everyone on this call? Here's a list of the products for this year's season, and this is always updated annually at immunize.org. I encourage you to bookmark that page, and next year, as we approach flu season, you can look for it for updated vaccines. But we know that trying to get all of these manufacturers in our space, trying to get our business, it's important to have an overall view of all the products that are available and how we're going to decide what to give. You'll notice that there's information on the sheet about how it's applied, if there's mercury content, if you have families that are that's important to you, or if you're from New York and you have to give preservative-free vaccine to certain age groups, the age range, the CVX code, which seems like something that we don't care about as pediatricians, but we certainly care about it electronically because that's what goes to your immunization registry, as well as the appropriate CPT codes that go with the vaccines. And I would encourage you, if you get new products year to year, make sure your systems are updated to make sure that the right vaccine gets hooked to the right CPT code. There are often times where people have given a couple hundred vaccines before they discovered they made an error and it was mapped to the wrong CPT code. So a good colleague and friend of mine was kind enough, Vince Iannelli, to give me this slide. We often say, so why the heck is VFC vaccine not coming at the same time as our private vaccine? And you can see there's a huge difference in the amount of steps in the vaccine delivery chain that are different. For us to get private vaccine, the vaccine supplier, we order it from them, they ship it to us, it comes to us. But for most states, and this is Washington State, vaccine supplier goes to McKesson, which is the VFC contracted nationally CDC distribution point. Then the CDC decides how much they're giving to every state, and then the state decides when they're giving it to providers. And some states it's as soon as they come, they give a little bit to all of their providers. In some states, they wait till they have all of it before they'll give it to any provider. And then the provider has to place an order, and round we go. So the streamlined chain that's different from private to VFC tells you some of the reason that this is a delivery challenge, but it isn't our fault, but it remains our problem. I would encourage all of you, if you can go back and note when you got your first supply of VFC and private stock this year, the American Academy of Pediatrics is doing a survey about the delivery of influenza vaccine during the season. We believe that there are disparities of care being made in the convoluted way that VFC vaccine is distributed, and we plan to use this to advocate for streamlined delivery in the future, or to find states that do this well and replicate what they're doing well. So please, if you have access to the information, you will get these slides, click on the link to the survey so that we can advocate on behalf of all of you so that our patients can get greater access to vaccine, whether they are private or VFC insured. I like to say that information is power, and there is a new updated specification to transfer information from your electronic health record system to the immunization registry. And there is now a provision and a coded data set that says we are out of stock. So whenever you have the availability of this tagging of information, I think it is really important for all of us as pediatricians to not only tell the immunization registry every time we are giving a flu vaccine or any other vaccine for that matter, but to also to tell our IS, well, I would have loved to have been able to give this vaccine, but I didn't have any. And in some cases, that's because the VFC is not keeping up with your request for products, and you don't have stock. So you can also use it to run a report. So if someone asked you how many missed opportunities there were to give immunizations, you could tell someone, well, I could have vaccinated another 500 children, but I did not have the vaccine when they were in my office. It's important also to be able to separate private versus VFC. So again, we can make the case for disparities of care if they exist, and then advocate to close those gaps. It's also important to use this data to improve vaccine delivery. And we all know that there are some states that are good about VFC and private borrow and payback regulations. If we have more robust data, we hope to be able to make this more universally easy so that, again, we can maximize the largest number of children at the point of care when we see them, and not have them leaving the office without us being able to give them vaccines that they should have received. So where to start for flu vaccine delivery, and that is way before October. So you want to start by being prepared, and what does that mean? That means that starting in February, which is a couple of months from now, you're going to need to figure out the count of your active patients who will be at least 6 months old as of, say, September 1st, because those are the amount of patients that you're going to want to be vaccinating next season. You should also calculate or be able to predict your practice growth and loss. Is your practice growing? Are you adding a new provider? Are you going to be downsizing? That will predict how much you are going to want to pre-order. You should also know the general percentage of your flu uptake vaccine for your practice in previous years, what percentage of your patients got vaccinated. I often find it interesting that if it's a bad flu season and a lot of people are sick, or there's a shortage, the next year everybody wants it. And if it's not, they sort of think it's not a priority. But messaging for this is important. And you may decide as part of a quality improvement project to decide, okay, last year our flu vaccine uptake was 60%. Let's try to shoot for 70 this year. You want to outline your pros and cons of which products to purchase. There are clearly advantages of using universal dosing regardless of age. There are advantages and disadvantages of doing shot only versus having nasal live vaccine or shot only. There are advantages and disadvantages of doing multi-dose or pre-filled unit dose syringes. You want to know how much you can return unused product without penalty. That will help you make it easier for you to decide, I'm going to shoot for 80% of flu vaccine uptake next year if I can return it without penalty. And then there are also some strategies around single versus multiple manufacturers. Should I try to get a little bit from everybody, not knowing that sometimes the delivery in the summer or September may vary based on manufacturers? Or does that just make it more complicated for my staff to try to figure out who gets what product, and I'm better off having one manufacturer? All of those things should be in a conversation, and you should start thinking about that in preparation for your February pre-ordering. You also need to consider your costs when you're doing your pre-ordering. There are clearly direct and indirect costs to vaccine administration. There are consumables. Something that most people don't think about is disposables. If you pay a lot of money to get your vaccine biologicals taken away from your office, and you're filling up more of those red boxes in your exam rooms, does it matter if you're doing mist versus injectable? Does it matter if you're doing multi-dose versus mist? But you should at least consider that. You also need to consider how you're going to pay to store this vaccine safely. Most of us don't have room in our regular day-to-day vaccine pharmaceutical grade refrigerator to do this. A reminder that safe storage is available on the CDC website, and they are in your resources of how to safely store a vaccine. In my office, we elected to have an overflow refrigerator that has no freezer in it. We do effective monitoring, but it is not our pharmaceutical grade vaccine that we use for our regular day-to-day. Our overstock we keep in its own separate flu overstock refrigerator, but freezing is probably the biggest threat to your vaccines. And so if you're going to do that, I would recommend that you do that with a refrigerator only, no freezer component vaccine refrigerator, and you still have temperature monitoring remotely so that you can be alarmed if something happens to your flu supply. You need to be able to talk about personnel costs, and remember, this isn't just the cost of your vaccine and how much you get paid for it, but you have to think about the steps that it takes for your staff, and if you're having multiple products, does that add to the complexity? There is insurance that everyone should have against loss of vaccine should the fall storm season hit you like Sandy did in the Northeast a few years ago. You want to be able to know what you're going to do and have insurance against your lost vaccine. And I want to make a plug right now. If ever anything happens to your vaccines and out of temperature and they have to be wasted, do not throw them away. Usually when they expire, most pharmaceutical companies will replace them for you. So don't ever throw away a lot of vaccine that was damaged based on temperature excursions. Hang on till it expires, and most of your manufacturers will replace them once the expiration date has been made. I encourage everyone who's not read it, the AAP business case for vaccine reminds us that we need 17 to 28% above our purchase costs in order just to break even, not make a profit. So make sure that you are paying attention to the math, and that business case, which is a hyperlink, will give you the data on how to make that happen. So prior to vaccine arrival, I would argue that everybody should have a flu task force in your office, and so that there are people poised and ready to act and reactively and proactively to make sure this happens throughout the year. You have to give them protected time to work and empower them to make a decision. Action items they should consider: practice agreement on office team receiving the vaccine, which means what are you doing about your hiring your new staff members, and are you going to require them to receive a vaccine, and have you had that signed on as their onboarding process of being part of your practice team? You're going to have to figure out what your messaging is going to be to their families and your messaging to your office team. Decisions about starting timing: if you get it in August, are you giving it in August? Are you waiting until Labor Day? Are you going to prioritize who you immunized based on your vaccine delivery? And you want to proactively have this decided and have a small team acting, so you don't have to wait for your monthly team meeting to make those decisions. Standing orders make this easier for the nursing staff and team members to do this without constant physician or provider intervention. Make your VIS available everywhere that you can find it, and then make sure that, again, that you know about appropriate storage and handling, and that hyperlink goes to the CDC toolkit that I mentioned in the last slide. So your practice messaging. I would be careful to make sure that all practice team members must be consistent. It does not help you if someone signing at the front desk says, does my child need any vaccines today? And the front desk staff says, well, they could get a flu, but I never give flu vaccine to my kids. That's not going to help you. You want to make sure that everybody's got consistent messaging and is on the same page about the importance of influenza vaccination for all patients 6 months and older. You want to use resources to emphasize the importance of the vaccine, whether you put posters or messaging in your waiting room or exam rooms, whether you put flyers up in your office or website alerts or on your homepage. You use your social media, your Facebook page, your Twitter feed to make sure and keep the messaging updated and current and as the flu vaccine delivery evolves. Usually in my practice in August, we mass email all of our families emphasizing the importance of the vaccine. We explain where they can receive with a hyperlink the information on vaccine information sheets. We also tell them how they will be getting updated information, tell them that it's going to be on our website to look forward to an additional email as supply comes, however you do it, but prepare them for what's coming so that they, instead of saying, oh, why don't I drive by the pharmacy, flu vaccines are in, they already had a message from you, they are engaged with you, and they will be looking to you for future messaging so that they can get appropriate vaccine administration in your office, in your medical home. Oops, I apologize. And now I'm going to backtrack. There we go. I apologize for that. My computer had a little flurry of activity. So limited shipment arrival, where to start and when to start. So this was a problem for all of us this year. I would argue that ongoing communication is your key to success. What you do about VFC versus private really depends on whether your state allows borrow and payback. I would say that under 3 years, immunize at sick and well visits as soon as you can, because those are the patients who may need 2 vaccines. And those are the patients that count for your HEDIS and your pay for performance. So as soon as you can, the youngest children and the most vulnerable probably should be carpe diem when you can. High risk patients, you may want to proactively outreach to your children with special healthcare needs or your asthmatics or chronic care disease, but you first need to figure out how you identify them and then decide how your practice is going to reach them. And again, that should be all part of your flu planning team before the flu vaccine gets to your office. And then there's specialty consideration about college students. There is always some deliberation about, is it too early to give the vaccine to college students in August? Well, they tend to leave for school in mid-August, so what I would argue that you try to capture them when you can. There is mixed data about the length of efficacy for the vaccine, but the CDC continues to recommend that you should try to vaccinate as soon as vaccine supply is available. And the AAP policy statement says that should try to get by the end of October as many patients covered as you can. We know that that was not possible at all this year, and it leads to a logistic nightmare, but that is still the recommendation, to start immunizing as soon as you can. So capturing every opportunity to vaccinate is important. That means training your staff to check for flu immunization status every time they touch a chart, whether they're triaging an appointment, trying to decide if a kid needs to come in for a cough or a cold, and they're looking at the chart, where your front staff is checking them in, whether they dropped off a driver's form or a camp form or a school form to be filled out. Training your staff to always look, what is this child's flu immunization status at every contact is really important. Even when you're processing a report from the specialist, to look and see, hey, I'm scanning this in or processing this in the electronic health record, is the child up to date? And then empower all your staff and providers to carpe diem and give flu vaccine at every possible opportunity. It is helpful to automate as much as possible so that this burden is minimized wherever you can. And standing orders often help that. That can be standing orders for sick visits, well visits, shot-only visits, picking up forms, or siblings. If you happen to be doing a well visit on a 2-year-old and the 4-year-old and 5-year-old is sitting next to you there, at the same time, your staff should be empowered to say, hey, Mom, why don't we get those 2 children also protected while you're here? You want to make it easy for your providers to order it, which means that figuring out which vaccines you're giving for which age groups and making it easy for them to order with 1 click. You want to have the ability to easily add it to a sick visit, and the AAP and CDC, unless the child is significantly ill with a high fever, for a simple cold or uncomplicated illness, it is safe to give a flu vaccine. And you want to make sure you have appropriate available products by age or VFC and private status, so that you're making it easier for your staff to fulfill the order. That includes making inventory available at the point of ordering when your providers are ordering. So when should you stop providing flu vaccine? Immunize.org says, as long as the viruses are circulating in the community and you have unexpired vaccine available, you should keep doing it. So I'd like to review some common practice errors that we often run across that I want to make sure that everyone is aware of. You cannot bill a nurse visit for a shot-only visit. Many practices do, and we've had several practices that do that, and they got audited, and all of that money got taken back and recapped. If you're charging a nurse visit when the child is in for a vaccine, it has to be for a separately identifiable reason, like a blood pressure check or a weight check. But you can't bring a patient in that says here for flu shot, or follow up from well visit here for shot not given at visit, unless there's a separately identifiable reason for the visit. If you use vaccine administration counseled codes, the CPT definition currently states that those codes are reported when the physician or qualified healthcare professional provides face-to-face counseling during the administration of the vaccine. So two things: some states change that qualified healthcare professional, and so you need to know your state's regulations, but it has to be the same day. If you counsel the patient for the flu vaccine or any vaccine today, but they're not getting it today, they're coming back next week, the counseling does not count. If they're only seeing the MA or nurse in your office for that visit as a shot-only appointment, you cannot use the counseling codes. And know that they're in many payment payers models, there is a difference in payment for the counseled versus the non-counseled codes, so it may make a difference how you handle those. Also, vaccine administration codes for 19-year-olds and up is different, so make sure that you're using that appropriately based on the age of the patient. Lots of practices say I'm getting a multi-dose vial because I can get more than 10 doses out and squeeze it out. You're not supposed to do that. You are only supposed to get the recommended doses out of a multi-dose vial and discard what is left over. You also should not pre-fill a large volume of syringes from a multi-dose vial, hundreds of them, and let them sit out for a day while you do a flu clinic. Those are hyperlinks to best guidance and best practice for both of those things. The ICD that's appropriate for vaccine administration is now Z23. It used to be separate ICD codes for every vaccine. Now Z23 is the appropriate code. And remember, it goes both to the CPT for the vaccine product and the CPT for the immunization code. So what do you do about flu refusers? This really, to me, depends on practice philosophy and goes back to your messaging. In my practice, the biggest priority is young children because they are the most vulnerable, and also because they are really part of your quality metric. If you have families that refuse, I would encourage everyone to document that in your visit notes if they're for a visit, including there is an ICD code for immunization not carried out because of caregiver refusal. I like to send that to the claim to my payers, so if at some point they say, hey, your rates are low, I'll say, hey, I tried to offer the vaccine and the patient refused. We also have found that using the immunization refusal form, which is also available in Spanish, and those are hyperlinks, makes people really say, you think this is so important, you're making me sign a refusal form just for a flu vaccine? And the answer is yes. We feel that committed that it makes a difference, that we want you to acknowledge that we have offered the vaccine and you have declined or refused it. Some practices, mine included, there's a SNOMED code for vaccine decline by caregiver, which we keep on the problem list, which is visible to the patients on the patient portal. So families understand that we really value vaccination rates, and it's a medical problem that they have refused their vaccine, and that we track that over time, especially if the patient comes in and then has the flu. So here's my practice experience example. We decided this year that we were only ordering the shot only. Again, that decision was made in February when we were still unclear what ACIP and the AAP was going to say about live vaccine as a preference or inactivated vaccine. So we decided we were staying with shot only, at least for this year, to see where the dust settled after this year's data. We also have families that ask us about preservative, and just to eliminate that question, we've decided to get pre-filled single dose. Unlike some of my colleagues, we decided to get both the 0.25 and the 0.5 because, believe it or not, our payers pay us in some cases $2 more for the 0.25 ml than the 0.5 ml. And when you multiply that by all of our young children under 3, that was significant revenue for us, and we elected to get both. We also decided to that we knew we were getting staggered supply this year, so we decided after Labor Day we would start giving what we had. And we messaged all our families saying we have plenty of supply, we don't expect that to be a problem. Our delivery is coming staggered and unpredictable. We're going to be giving it to patients who are in the office for visits as supply lasts, and their siblings. We took advantage of that. And we will be scheduling our Saturday flu clinics as soon as we have guaranteed stock to cover a large volume of patients, because we vaccinate a lot of patients on those days. So this is 2 of my patients, and this is shared with their permission. This is several years ago. If any one of you remember the H1N1 outbreak, which happened in the fall, and we all got hit by surprise, the quote swine flu. We decided in my practice I needed an automated way, because all of a sudden I had all these patients and an additional flu vaccine to deliver the H1N1, and how was I going to recall all my patients and get a maximum number of patients vaccinated? And so that was the origin of the way that my practice deals with automated flu clinics. And these are some of my patients who thought it would be funny because it was on Halloween. They came with their pig noses as part of the swine flu clinic. But what happens is we scheduled a flu clinic now for the end of October. It's actually the 26th coming up. We decided this flu clinic was going to be 3 years up and only, and shots only, because we don't have to undress babies and everybody's getting the same vaccine. It makes it easier for us to process more patients quickly. We identified in the electronic health record all of our active patients 3+ years, and we send a mass email inviting all of them to log on to their portal account and self-schedule an appointment for the flu vaccine. The email contained a link to the VIS. The self-scheduling, the act that the family scheduled the appointment, actually places a standing order for the vaccine on the appropriate appointment, and we will plan to see 10 patients every minute. So this is what this looks like for the 26th, and all of those white spaces are patients who made their own appointments. My phone did not ring, my staff did not have to process, and when they come in for it, they will have a standing order for the vaccine that the nurse simply clicks, and they're finished. We have, for flu clinics, surprisingly enough, 2 providers check the families in. We've done this on purpose because we believe that the flu clinic is, when we do several hundred patients, is an all-practice joint effort. And since the providers are the people checking families in, we do the counseling as part of our registration, and then we can bill for the vaccine administration codes. We have the sign posted on the door and in the waiting room, and we tell any of the families, if the answer to any of these is yes, then please tell the doctors as you're checking in, and then the doctors take those patients off sort of out of the line and deal with them appropriately. We have 4 nurses administering the vaccines, a standing order for the vaccine. You go in one door and out the back door, and the vaccine administration recorder in the EHR allows for the inventory to be decremented, the patient's chart to be updated, automatically generates the vaccine product and appropriate administration codes, and sends to the immunization registry. And we process, yes, those patients that fast. I would encourage all of you to think outside the box as you approach this in your practice. Everybody's setting is differently. There are some practices that have done drive-through flu clinics, and some public health organizations do this. When H1N1 needed to be distributed, our local Department of Health did this at our local schools. There has been some skepticism about, don't you have to have patients waiting, and what if they faint and they're driving off in a car? If anyone pushes back on your drive-through clinic, there is a link to research that has shown that fainting is not a concern. And many pediatricians have gotten on board of this if they have a amenable physical location where you can drive a lot of cars through. My parking lot's too small, but we definitely can sort of get in the front door and out the back door in a fast enough manner that this has not been an issue for you, for us at least. I would encourage you to use social media to promote your flu vaccines. whether it's Twitter or Facebook. Give your families an opportunity to also tweet or follow your practice. These are shared from some of our practices and my practice as well. Our Pediatric Success Series, if you would like to, we would encourage you to share your flu vaccine for your staff by tagging us at PD Success. Please remember, if you're using patients, to have their permissions to share their photo, and also at least get verbal permission from your staff if you're going to promote. But this is one way to show our families that we are absolutely on board and vaccinating our staff to protect them as well as the community. So family members, some practices, this is interesting to give the family a convenience. We've often had parents say, hey, you guys are way more efficient than my doctor. Can I get my flu vaccine while I'm here too? This may provide more value than getting somewhere else in the community. There are a couple of things to consider. Some practices use cash only. You need to understand that if you are participating with their insurance company, and sometimes that's very common because you're seeing their children, which may have the same insurance, you may actually be violating your contract to ask them to pay cash. You need to register them as a visitor and gather insurance information. If the parents are part of a capitated plan, your claim may fail if you're not the PCP. And we have found at the American Academy of Pediatrics, as I'm chair of the Payer Advocacy Advisory Committee, that sometimes if a parent gets a flu vaccine in your office and doesn't get care anywhere else during the year, they are being attributed to your patient panel. And then your quality pay for performance metrics want to know why you didn't also get do their well visit, and they didn't get their mammogram or other preventative care services on time. So that doesn't mean that you shouldn't do this, but you should explore all the possibilities and before you decide to take on vaccinating family members. So I'm going to turn this over to Kimmy. That's a lot of information, but I'm happy to entertain any questions, which we can discuss for the remainder of the time.
Perfect. Thank you so much, Dr. Kressly, for a super informative presentation. Before we hop into any of the questions from the audience, I just simply wanted to review a few of the items that I mentioned earlier. All attendees of today's live webinar will receive a copy of this presentation, the webinar recording, and their CEU certificate in your mailbox within 48 hours. For those of you who are interested, you're invited to stay on the line after the Q&A session for a 5-minute overview of today's webinar sponsor, Office Practicum. When you leave today's event, you will be receiving a brief survey. We ask that you please provide your feedback so that we can improve our future webinars like this one. As part of the survey, you will be able to request follow-up from an OP representative regarding OP products and services. And finally, be sure to check out our new website that I touched upon earlier. The website is pediatricsuccessseries.com, and don't forget to connect with us on Facebook and Twitter, which you can find at PDPDI Success. And with that, let's hop into some of the questions that we received from the audience. Your documentation process sounds quicker than ours. Do you enter an encounter note for each flu vaccination?
So that's interesting. We actually do, but we have an encounter note for a template that's flu vaccine only with pre-answered questions. And you will notice that those questions that were asked that were on the screen for our check-in process at our flu clinic are all answered in the affirmative way, so it's okay, and then our staff changes it if we need to. It already has a standing order for the vaccine itself. It already has wording in there that says verbal permission granted by parent for flu vaccine and VIS given. So all of that wording is in the template, but simply a matter of, and no, we don't take temperatures for every kid who comes in the flu clinic unless they say they're sick and we want to pre-screen them as the doctors. But we simply open the template note, which already was there because they self-scheduled that way, and then the nurse clicks on the vaccine to administer, and then we're done. So it was streamlined automation through templating and use of the technology that's available to us.
Perfect. And another question that we had from the audience is, how would I explore a P4P with my payers?
So it depends on whether you can get someone to talk to you. If you actually have a contact at your payer, start with them, your payer representative, and say, are there any quality measure performance based on immunization rates on our well visits that are available to us? I would also encourage you, most of the AAP state chapters have pediatric councils, and they are available and can explore that with you, or your AAP chapter may be able to help you find out what's available to you based on the payers that are in your region.
Do you have a recommendation on how many flu clinics should be held during the season?
So some of that depends on how you want to set this up and how many patients you have, right? So we have about 3,400 active patients, and because we were catching a lot of patients as we went, since we were getting staggered supply in September and October, we'll do another 400 to 500 next Saturday, and then we'll look at it fewer, and we'll probably usually do 2 a month apart. We also in the past have done self-scheduled flu clinics that we don't do quite as many at a time, with our nurse only appointments after school from say 3 to 6 o'clock on a Wednesday afternoon, which tends to be our lightest in our office, and then families can sort of fill those. We don't do that many patients per minute, but we do, one every 10 minutes for the nurses to squeeze in so that families can do after school as well. So part of it depends on really what the size of your patient population and your ability to do this on weekends after school, and perhaps use additional nursing staff or MA staff to get it done.
And do you find that you have to incentivize your staff to work those flu clinics?
Well, I think we all like to be incentivized to work extra, and so yes, actually we do give sort of a bonus payment for nurses who are willing to work that extra time. But we also, as part of my practice design, share our profitability with our team members as a practice as a whole, so they know that we talk about our pay for performance metrics and what we need to hit to be successful, and that keeps the practice successful, and they share in that success. But I think that it also depends on paying your staff in the currency that's important to them, and some of the staff members would rather have an afternoon off to go to their kids' Halloween party than extra money, and so you figure out really how to do this within the scope of what are your rules based on your employment law in your state, and what incentives actually will work for your practice team.
Are you billing a 90460 on your flu clinic days, since the providers are checking the patients in?
We are using the vaccine administration code that includes counseling, because yes, the doctors are counseling.
And this one is not completely on the subject of flu vaccine, but this practice is having issues being paid even cost for vaccines. So we are a small practice, and it seems carriers are not as willing to negotiate. Any good resources you can recommend or contract negotiations? So
I would say start with 2 things, one of which is joining the section on administration and practice management, or SOPAM, of the American Academy of Pediatrics, and I can share that information with you, Kimmy, that you can send out as part of the wrap-up, where your colleagues in your state can help you figure out how to do this. And that starts with making sure you're paying the lowest amount of cost for your vaccine, which is joining a vaccine purchasing group. And there are also some resources available about where you can join vaccine processing groups. purchasing groups, I mean, in your region. So I'll include some of those links to some of those resources in the follow-up email so that we can share it with our attendees.
Perfect. And somebody else just said, I'd be interested to hear what your provider counseling looks like during your flu clinic. Do they have a script that they can use?
Well, a lot of it, we actually, we have printed sheets and we say, you know, we believe in flu vaccines. The reason for the flu is to prevent flu. Here's the vaccine information sheet. You may take one if available. Do you have any questions? I'd be happy to answer it. Most patients have no reaction, but you may experience mild soreness, low-grade fever, and mild symptoms for the next 24 to 48 hours, and it's sort of and usually it's a family that's presenting, so you sort of can sort of overhear, and then the next family of 9 might say, yeah, I just already heard your spiel, so it becomes pretty effective at getting a little pattern down.
And on that one, do you get parent consent signatures for administering the vaccine at your flu clinics?
We do not. And you should know, and I'll add this link for you, Kimmy, too, to also provide to our attendees.
Perfect.
The federal law says that you do not need written consent for vaccines. There may be state VFC laws that are going above beyond that law, but no, that's the flat one. So don't make an assumption you need a consent. And from my standpoint, if you're coming to a flu clinic and you showed up with your kid and you're already consent to care, that's overkill. So we do not get vaccines. Our template says verbal consent granted by parent or caregiver, and because the verbal consent is there if you're saying, who are you? We're going to give you a flu vaccine. You're all right with that? Yes, here we go. So we do it with verbal consent that's documented in the template for the note.
Perfect. And since we are nearing the top of the hour, I will use this as the last question. How do I know if I'm allowed to use private vaccine for VFC and vice versa in my state?
So the best source of truth for that is to ask your VFC, what is your borrow payback and how I'm allowed to do that, and what kind of reports do I need to support that at the end of the end of the season, or how often do I have to report them. This is so different across all of our 50 states that you want to get your source of truth with your VFC, but don't take it verbally. Ask them to show you in writing, because some of the VFC people that come to your office actually don't know the letter of that law, and you want to make sure that you have it. And if it is an onerous barrier to making sure your kids get vaccinated, join the advocacy conversation at the AAP on SOPM and other various advocacy committees so that we can close the gap and remove that obstacle to getting all of our kids immunized with flu appropriately.
Perfect. And thank you again, Dr. Kressly, for all of your expertise, and thank you to all of you for attending today's event. If you are interested in learning about Office Practicum, the sponsor of this webinar, please stay on the line for a quick 5-minute overview of OP's products and services. And with that, I would like to introduce OP's Senior Account Executive, Brett Cleary. Brett, I'm not sure if you are currently on mute or not. Let me just let him know that we can't hear him.
Can you hear me okay?
There you are. Sorry about that, guys.
I apologize about that, guys, but I appreciate your patience. Yeah, hey, what I wanted to mention was thank you to Dr. Kressly. What great information about for any practice to hear, and we're thrilled that these tips are going to be able to benefit our existing OP community members on the line, as well as the pediatricians and administrators who have joined our call today. Our mission, whether you've been an OP customer for 25 years or you are just hearing about us today, we hope to have a few more minutes of your time to share how OP's tools can add value to your practice along the techniques Dr. Kressly has just shared. OP's mission is improving health through technology. Our electronic health record practice management system, our billing services, and business analytic tools help pediatric practice improve clinical and financial outcomes. As far as OP at a glance, again, thank you to the existing OP users on the webinar today who've added their patients and practices to our community. We never take for granted how important these relationships is that you have to your patients and that you trust to help manage the 6 million lives presented in our systems across the country. If you're interested in joining the OP community, we'd love to talk more. We have a 98% retention rate, and I'd love to tell you a little more about why practices who use OP love OP and see it as a part of their long-term plans. What I wanted to do in the few minutes that we have this afternoon is really talk about some of the parts that are within OP and go through a couple different slides. And then I want to kind of put those words into action and actually show you how that looks like in office practicum. But to begin with, as Dr. Kressly mentioned, the practice should capture every opportunity, and OP users will have good visibility if a practice is in need of a flu vaccine. Within OP, a provider or a nurse or a staff member can see the flu vaccine information in what we call the edit appointment screen. We have an OP chart overview, actually in the immunization charts, in our order plan area, and obviously in telephone triage. And again, shortly, I'll show you some of those areas within OP where these items are visible. As far as OP vaccine inventory, this is always interesting. I work with a lot of prospective clients all over the country, and unfortunately for a lot of practices, they don't have a really good handle as far as their vaccine inventory. They don't have a good system. Their current system doesn't allow for good vaccine inventory. But with OP's vaccine inventory, it's in real time, and it will help determine if your practice has ample supply of the flu vaccine or other vaccines for that matter. With OP's vaccine inventory, you can quickly identify the vaccine's name and amount available in your fridge. You can see the value of the inventory, including the total value of all your non-VSV vaccines. OP provides the expiration date. So perhaps you may want to do a vaccine recall report and seek out those patients who are overdue or behind for vaccines, so you don't have to perhaps maybe eat the cost of that vaccine. In addition to that, OP does have a very strong, what we call demographic analysis recall solution, and a service called OP Notify, which allows your practice to stay in touch with your patient, or your parents. And the OP's demographic analysis will quickly allow you to find those active patients, drill down to specific criteria, and find those kids that are overdue or behind on that flu vaccine. And there's always two parts of the equation. You've got to find the patients that need, in this case, maybe a flu vaccine, and then message maybe mom or dad that the child is actually overdue for the service. And OP Notify will communicate that message. As far as OP Notify, if you've ever attended a previous webinar, you may be familiar with one of our newest offerings, again, called OP Notify. By partnering with IntelliChart, we've begun to enhance your patient engagement solutions through automated appointment reminders in a set and forget way that communicates with patients in a method they prefer and reduces your no-shows on your calendars. This includes, first of all, as far as OP Notify, it's fully integrated within the OP application. Seamless demographic exchange of information. You can send these messages via email, text, or call. Those are reminders or for overdue care plans. Ability to schedule and automate communications. We've got a robust HTML editor from modern look and feel, and multiple event types and advanced recipient targeting. And as far as the OP community, this is obviously not necessarily a feature within Office Practicum, but more in a broader sense, having access to the OP community. So when you're partnered with OP, not only do you have access to industry-leading pediatric-specific technology, but you also become part of this OP community. This network of like-minded physicians, providers, and office staff across the country are solving some of the most pressing problems in pediatrics together. OP gets a lot of great ideas from our fantastic medical directors and our OP employees. However, thanks to over the 4,000 pediatricians, they have helped contribute and submit some great features and ideas that actually get put into OP. So we're always evolving our software around pediatrics, and a lot of that at times comes from the people that use OP, our users. Our clients will obviously use the OP listservs. We have listservs for practice administrators. We have listservs for providers. We've got webinars like we've done today. We also do private webinars for just our clients. And of course, we do the OP user conferences as well. So, and that allows our clients to network with each other and again, talk about those real problems that they're facing in a pediatric setting. So, but with that said, like I said, let me go into and show you a little bit about Office Practicum as we were mentioning earlier. When you go into your vaccine inventory, and this is one of the things that Dr. Kressly mentioned, but what's important about this part of Office Practicum, really, I think for a lot of people, is they like this number down here. They want to know the value of the inventory, $84,866. That's what's sitting in your fridge. And so, but what you can also do is if you actually highlight one of these vaccines, like one of your flu vaccines, you can see how much is available. You can obviously see when the expiration date is, what's the value of that inventory. And so for a lot of our practices that use Office Practicum, what they'll do is, for example, if we do this, and maybe this Hep A dose down here, well, we've got 99 doses left, and it's going to expire in about 2 months. So what we may want to do is identify those kids that are behind or overdue for a Hep A 2 dose and go ahead and message them, and what we call that is a vaccine recall. But this vaccine forecast really does help, especially when we're talking about flu and some of these other vaccines. As I mentioned earlier, we have a demographic analysis recall. So if I go to that, what we can do in Office Practicum is we can identify our patients, and we can do it by how many kids that we consider active. Maybe it's in the last 3 years since they've actually come in. We can do no data restrictions as well. But once you have identified your patients, and I've got about, I've got some patients here, what we can do is then we can come over here and say, well, you know what, I just want my 5-year-olds, and I also just want my kids that are part of Cigna, as an example. And once we've identified these kids, we can actually do that vaccine status recall. We can identify, let's see, the kids that are behind or overdue for that flu, since that's our topic today. And once we do that, it will search out these kids that meet that criteria. And we found these kids that are overdue for 5 years old. They're Cigna patients. They're overdue for a flu shot. So once we have these kids, really, like I said earlier, there's 2 parts to the equation. Number one, you want to go ahead and find the kids. We did that. And the next part is we want to go ahead and send them a message. And that's the nice thing with that OP Notify, as we were talking about earlier. We can do a flu recall, and we can set up our own messages based on their preferences as far as how they like to be communicated. Some want to have phone calls, a couple want emails. And these emails might be a little bit longer. Maybe we want to talk about that flu clinic that we're going to have in a week or two, things like that. And now we can go ahead and message our patients. And same with text messages. So, and then with text messages, it might be a little smaller because people don't really want to see a very long text. But the idea being with the OP Notify, you can certainly get that out to your parents, and hopefully the call to action, they'll call to practice and get on the schedule. As we mentioned earlier, there's a couple other different ways, and I think for your staff and for your providers to help them see that they have a child that they're working with that is overdue for a flu shot. One of the areas is what we call our edit appointment screen. It's right here. And certainly this patient is calling in, and it looks like mom has called in or dad's called in, and their child has a sore throat issue, so we've documented that. But really the key area of information right here, this is very important as well, because we can see right here, as of today, they're overdue for a flu shot. So that conversation might change. Let's get them in for, for the sore throats, and oh, by the way, it looks like you need to get a flu shot, and maybe have that conversation, which might lead to perhaps another visit. But also, and I always like to mention this, I can't get away with not showing this, we always will let your front office staff in this case know that if this patient's overdue for a well visit, it's highlighted in red. So again, that conversation might change, that they might need to get a flu shot, they might need to get in for a well visit. But this is just one area where at least your front office staff can be proactive. In addition to that, when we're actually in the actual patient chart itself, and as a provider, what's great about OP is it'll tell you the vaccines that are recommended for right here. I could actually go into the immunization chart and actually confirm this, but it does give that, tells you if they're VSC, yes or no. And then when you're looking for your vaccines, for example, that flu vaccine, which is right here, what's great, we'll keep in track in real time how much vaccine, how many doses do we have back for our private or commercial paid patients. We've got 100 doses. We can order with confidence, right? So in addition, once you've actually identified which vaccines you want to administer, you either can create an item for your nurses to go ahead and get those vaccines administered, or you can certainly do these now if you want to as well, and go and create this. We'll give this shot in the left arm. What's happened is once we've actually given the vaccine, it's captured the information such as the obviously the vaccine itself, but also the admin codes. Those are obviously captured as well. And the last thing I wanted to mention with the time I have mentioned is, and again, when you're doing triage, what you can also do is, let me bring up my triage screen here. I've got a patient right here. We've brought this patient up. Her name is Molly Bryan. So when your phone triage nurses are actually bringing up patients, and we're going to send a message to Dr. Hatfield, looks like they want to call about travel advice, going to Thailand, needs information on vaccine. Well, you can come over here. We've got a snippet of the chart right here, and we can see basically they're overdue for a flu shot. So when you actually, again, every opportunity, when you create your opportunities and you have good visibility, you can certainly go ahead and look at to see if they're overdue for whether it's this particular flu shot or maybe other vaccines as well. So, but that kind of gives you just a couple different ideas as far as where in OP you can identify if they are overdue for a flu shot. So, but sort of in closing remarks, again, I want to thank Dr. Kressly for sharing her time and wisdom with all of us. If a member of the OP team can be of assistance with and the products you've mentioned today, such as OP Notify, make sure to request a follow-up on the post-webinar survey. And certainly if we piqued your interest today, certainly go ahead and, for the first time at least, be sure to check the yes if the webinar survey, on the webinar survey. We'll be happy to have a business development specialist contact you and give you a personalized demonstration. And then finally, if you're going to be attending the AAP National Conference next week in New Orleans, we'll be in booth 1133.